everyone. I'm Dr. Joycelyn Lee from the National Cancer Centre Singapore, and good afternoon to everyone, and thank you for joining us today. I'm a medical oncologist for patients with pancreas and other GI cancers, and I'm really happy to be meeting all of you online for our public forum today. So November is Pancreas Cancer Awareness Month, so it's really timely that we have this forum now in the middle of November. And purple is the color for pancreas cancer, so you may notice why our color theme today is all largely purple. So pancreas cancer is a very difficult cancer, both for patients as well as for doctors and nurses to manage. So we'll be having a very interesting lineup of talks today. I'll show you the program as we move on to the next slide. So to start off with, we will have Dr. Tan Hui Leong, who will be talking to us about pancreatic cancer, what to look out for and how to get help, telling us about some of the symptoms and some of the basics of pancreatic cancer that we should all know. Next, we'll have Dr. Joanne Yao, who will be talking to us from the perspective of cancer genetics. With a talk entitled My Family Member Has Pancreatic. Lastly, we have Ms. Juliana B, who will be taking us on a very special sharing of a patient and a caregiver's journey in overcoming pancreatic cancer. So without further ado, I'll introduce the first speaker, who is Dr. Tan Hui Leong. Dr. Tan is an associate consultant at the Department of Hepatopancreatobiliary and Transplant Surgery at Singapore General Hospital. He graduated with MBBS honors from Yongludin School of Medicine, NUS, completed his general surgery residency in SingHealth, and his research and clinical interests are in the evaluation and treatment of hepatobiliary and pancreatic malignancies. Dr. Tan, please.
Hi, thanks, Dr. Lee, for the very kind introduction. So, very good afternoon to everyone. I'm Hui Leong. I'm one of the associate consultants with the Department of HPB and Transplant Surgery at SGH. So today I'll be kicking off today's series of talks by sharing with you some basics on pancreatic cancer, what to look out for from a patient or a prospective patient's perspective. And hopefully after this, all of you will have a deeper understanding of this condition and how you might be able to seek help if you're worried or someone you know actually has it. So let me share my slides with you guys. All right, okay. So we'll start. Okay, so my talk is titled Pancreatic Cancer, what to look out for and how to get help. So firstly, this will be the scope of my talk today. So first, we'll talk about what pancreatic cancer is, what the pancreas is as an organ, who are actually at risk of getting pancreatic cancer, what are some signs and symptoms that you look out for in terms of how pancreatic cancer presents, and should we suspect pancreatic cancer when you see a doctor, what kind of investigations do we then perform to investigate it? And thereafter, if you were to be diagnosed with pancreatic cancer, what are the treatment options available out there? And lastly, what are the outcomes like after treatment for pancreatic cancer? So firstly, before we talk about pancreatic cancer, I think we need to first know what the pancreas is. So the pancreas is actually an organ that all of us have. As you can see in this diagram, the pancreas is actually located in the upper abdominal region, just behind the stomach. So it's a very interesting organ. It has multiple functions in your body. One of its main functions, firstly, is to help you digest your food. So it secretes a series of enzymes that are then emptied into the small intestine, mixes with the food that you eat, and that actually helps in the digestion process. Another very important function of the pancreas is actually it secretes various hormones, the most important of which is insulin. And this actually helps to regulate your blood sugar levels. And that is also the hormone that's actually deficient in some patients who have diabetes, for example. So the pancreas, as you can see in the blown up diagram in the bottom right-hand corner over here, actually comprises several portions. The part that is actually hugging or being hugged by the small intestine over here is the head of the pancreas. The middle portion is known as the body, and the portion all the way to the person's left or the right on the screen here is called the tail of the pancreas itself. So when there's pancreatic cancer, essentially there's a tumor that actually grows from the pancreas itself. There are many different subtypes of pancreatic cancer, but the most common of which actually arises from the lining cells of the duct, which is a tube within the pancreas, which is responsible for emptying the digestive enzymes that we talked about earlier into your small intestine for digestion. So as you can see over here, the tumor can arise from the pancreas itself, and depending on the location, as it grows and invades into surrounding structures, it can cause a variety of problems, and that then presents with certain typical signs and symptoms which you may want to look out for, which we'll talk about later. So before we get that, then we'll ask the question, who gets pancreatic cancer? What kind of people are at risk for pancreatic cancer? So many studies have been done on this, and this is not an exhaustive list, but these are some of the more common risk factors we talk about when we talk about pancreatic cancer. So firstly, with that of cigarette smoking, strongly associated with pancreatic cancer amongst many other cancers. Obesity, as well as a Western type of diet that's high in processed foods, red meats. Patients who have diabetes. Patients who have what we call chronic pancreatitis, which is an inflammation of pancreas itself. So some patients can get recurrent or repeated episodes of pancreatitis, and one of the most common causes of chronic pancreatitis is that of chronic alcohol drinking. And last but not least, there is a hereditary component to some patients with pancreatic cancer, or what we more commonly known as having a family history. So in certain patients, they might actually have a family history of both pancreatic as well as other cancers. So next, we'll look at how pancreatic cancer presents. What are some signs or symptoms to look out for? So pancreatic cancer often starts off very insidiously. Often when it's diagnosed, it's already quite locally advanced, it's quite big, or it might have already spread to other organs. So if there were to be any symptoms, usually, one, there can be pain. The pain from pancreatic cancer usually indicates that the cancer is quite advanced, because for the cancer to cause pain, it's usually quite large and would have invaded to the nerves that's surrounding the pancreas itself. Another very common presentation of pancreatic cancer, which is often how many of them are picked up, is when patients get what we call obstructive jaundice. So jaundice, as some of you may know, is a condition where there is yellowing of your skin, as well as the sclera, which is the white of your eye. And this is a result of a blockage of the bile duct, which, if you recall earlier, is also closely related to the pancreas itself. This causes the bilirubin, which is the yellow pigment that's often secreted by the liver, to be emptied into the small intestine to be blocked. And as a result, it builds up in your body, deposits in your skin and your eye white, and hence you turn yellow. Other symptoms that can result as a result of this would be tea-colored urine, as well as pale stools. And last but not least, some patients also present with an unexplained loss of weight and appetite. So as you can see over here, patients with jaundice, basically they have yellowing of the skin and eye white, and they might report tea-colored urine that looks very dark, uncharacteristically, during the same episode, and they'll be complaining about pale stools as well, as opposed to the normal dark brown stool color that we're all used to. So if you were to present to a doctor with these symptoms and they're worried about potential pancreatic cancer, there are various investigations that will be performed. Firstly, in terms of blood tests, we usually will check what we call a liver panel. This will confirm that the bilirubin level in your blood is actually high, accounting for the jaundice. There are some tumor markers that we can use. They are often not used as a definitive tool to diagnose the cancer, but they can help us and guide us in the potential causes of your presentation. Next, in terms of imaging, the most useful investigations for trying to look at the pancreas, which is a deep organ in your body, is actually some form of what we call cross-sectional imaging. So the most common scan we perform in the hospital is the CT scan. In some cases, the MRI scan might be useful as well. This will, one, confirm whether there is truly a growth in the pancreas itself, tell us where it is, how big it is, and also potentially give us information on whether it is suitable for surgery to take out, and whether there's any spread of the cancer to other organs, both in and out of the tummy itself. And last but not least, some patients will also require what we call endoscopic evaluation. So these are investigations that are performed a little more invasively. So they require the passage of a scope, or what we call an endoscope, which is a long tube with a camera at the end. And this scope is usually introduced through your mouth, down your food pipe into your stomach. And from there, where it's actually next to the tumor itself in the pancreas region, various things can be done. So an example over here is what we call an EUS, an endoscopic ultrasound. As you can see over here, there's a tube, which is the endoscope that's passed down the food pipe into the stomach. And when it's in the lower part of the stomach, you can see that the tip of the tube where the ultrasound probe is now adjacent to the head of the pancreas where the tumor is. So this will, one, allow us to perform an ultrasound on the inside to take a better look at the tumor, characterize it. And at the same time, as you can see in this picture, there is actually a channel for us to pass a needle through the wall of the stomach into the tumor of the pancreas. And this will allow us to obtain some cells. And these cells can then be sent to the lab for further testing and confirmation as to whether there are cancer cells seen. So once a patient is diagnosed with pancreatic cancer, then the next question naturally would be what treatment options are there for pancreatic cancer? So the overall treatment options that we look at will depend on a few factors other than the tumor itself. So one, we need to look at the overall fitness of the patient. Pancreatic cancer often presents in patients who are elderly, and often they might be frail or have multiple pre-existing medical conditions. If the patient is suitable for surgery, the surgery is usually quite a big operation with significant risks during and after operation. As such, it's important for us to first assess whether the patient would be fit for a major surgery. Secondly, we need to look at the tumor itself, whether it's resectable, or in simpler terms, whether we are able to take it out safely and cleanly, leaving behind no tumor. And this is both a function of how big the tumor is, as well as the relationship of the tumor to important surrounding blood vessels and structures which we cannot sacrifice. And last but not least, we need to look at whether there's a presence of distant metastasis or whether there's a presence of spread of the cancer beyond the pancreas itself. So common organs that the pancreatic cancer can spread to include the liver as well as the lungs. And once the cancer has spread beyond that, it's what we commonly call stage 4 disease. And that's when a complete cure through surgery will not be possible anymore. And thereafter, after assessing these various factors to decide on treatment options, the overall treatment intent can either be curative, in which we think that a patient is fit for and the tumor is still suitable to be completely taken out, versus if it's palliative, be it because the patient's not fit for surgery or because the tumor itself has spread or we can't take it out safely, in which case cure is not possible, and hence the treatment intent is primarily symptom directed, and we are aiming to try to slow down the progression of the tumor, and in the course of doing so, also try to alleviate any symptoms the patient might be experiencing from the growth of the cancer. So firstly, in terms of surgery for pancreatic cancer, it is currently still required for any chance of cure or curative intent. As mentioned earlier, surgery for pancreatic cancer is usually a very major surgery with very significant risks of complications as well as even death during or shortly after surgery. So a diagram over here illustrates a very common procedure we perform for head of pancreas cancers that are growing in the head of the pancreas. It's what we call a pancreatoduodenectomy or Whipple's procedure. As you can see in the diagram on your left, the area that's a bit more grayed out represents the area that we chop out. So that includes the pancreas itself with the tumor, as well as the gallbladder, the lower part of the bile duct, as well as the small intestine that is encircling the head of the pancreas. After we take out all these organs, then we need to reconstruct to ensure that everything that we've taken out and hence caused to be discontinuous, that continuity is restored. So as you can see on the right side, things are sewn back together. So the bile duct is sewn back to the small intestine. The remaining part of the pancreas is also sewn back to the small intestine, so the digestive enzymes can be emptied back into the small intestine to digest the food you eat. And the stomach itself is also joined back to the small intestine itself. Other than surgery, there are also other treatment modalities available for pancreatic cancer, such as chemotherapy and radiotherapy. So chemo and radiotherapy can be used in a curative treatment intent as complements to surgery. Sometimes it can be given before surgery, or what we call neoadjuvant treatment, or it can be given after surgery is performed, or what we call adjuvant treatment. The aim of giving additional chemo and/or radiotherapy in addition to surgery is to try to improve the overall outcomes and to try to decrease the risk that the cancer comes back in the future, even after we've managed to take it out through surgery. In cases where the patient is either not fit for surgery or the tumor itself is not suitable for taking out because it's spread or because it's too locally advanced to be taken, then chemo and radiotherapy can also be given in the form of primary palliative therapy where they are mainly given to control the tumor, try to hopefully slow down the growth, and hopefully prolong life by a little for the patients. In terms of the outcomes of the treatment, as I think Dr. Lee alluded to right at the beginning of the talk, pancreatic cancer, till to date actually, still has a very poor overall prognosis. Of all the patients who come to the hospital and eventually get diagnosed with pancreatic cancer, barely a fifth of them are actually resectable at the point of diagnosis, meaning about 80 to 85% of them at presentation are not even suitable for surgery or a chance at cure upfront. Even after curative surgery, the survival depends on a few important prognostic factors. One very important factor that determines the outcomes would be whether the lymph nodes, which are these small little pea-like organs around the pancreas itself, where cancer can spread to, whether they are already involved with cancer. If there are no lymph nodes that are involved, as we find after surgery, 5-year survival can be as high as 30%. But if lymph nodes are involved at 5 years, perhaps only 10% after surgery are still alive. Survival after surgery also depends on what we call the resection margins, meaning after we chop the tumor out, whether it's cleanly taken out, whether there are microscopic or macroscopic tumor cells that are left behind in the patient. And last but not least, whether patient receives any form of complementary treatment, as we mentioned earlier, such as chemo or radiotherapy, and if they successfully finish it. And these also has an impact on the overall prognosis for these patients after surgery. So in conclusion, it's the take-home message for everyone present, perhaps, it's to seek medical attention early, especially if you have some of these red flag symptoms, such as painless obstructive jaundice. If you find yourself turning yellow for no reason, your urine's turning very dark tea colored, and you have pale stools. If you have any unexplained weight loss, you're not dieting, you're not trying to exercise more, and yet you find your clothes getting looser, you're losing weight for no reason. Or if you have persistent abdominal pain that's new onset, especially when you're older, that you've never had before, and it's very resistant to treatment that's prescribed by perhaps your family physician in terms of Panadol or gastric medicines, and yet the pain is still present. These are things that perhaps should raise alarm bells, and you guys should then seek medical attention early to make sure that it's not something more sinister. And if and when you're unfortunate enough to know someone who's diagnosed with pancreatic cancer, the best chance at long-term survival would be some form of multimodality treatment if possible, and with combination of surgery, chemo, and perhaps radiotherapy. Thank you.
Thanks, Dr. Tan. That was a great talk. I think everyone really enjoyed it. We'll leave the questions to the end. If you have any questions for Dr. Tan, please feel free to put them in the Q&A box, and we will address them at the end of the whole session. Next up, we have Dr. Joanne Yao. Dr. Joanne is a senior consultant in the Division of Medical Oncology at NCCS, and also associate professor at the Lee Kong Chian School of Medicine at NTU. More importantly as well, she's also head of the Cancer Genetics Service at NCCS. So today she'll be talking to us on cancer genetics and pancreatic cancer with her talk entitled, "My Family Member Has Pancreatic Cancer, Should I Be Worried?"
Thank you very much to Dr. Joycelyn Lee and Dr. Tan for that very good talk just ahead of mine. And thank you to the Singapore Cancer Society for actually organizing this forum. I think I was given this topic because it does come up quite a lot in the clinics when caregivers come in with their family members with pancreatic cancers. This is a fairly common questions that doctors are asked. So for today's talk, I'm going to go through very quickly, again, the risk factors of pancreatic cancer. Dr. Tan has already covered some of that, but I'm going to focus mostly on the family history side of things, as well as what are some of the hereditary causes for pancreatic cancer. And because to understand hereditary and familial cancers, one must understand a little bit about genomic medicine. I'm going to run through with you what that is, and also who needs to consider genetic testing, what actually is genetic testing, and how can it help in terms of managing cancer risk for family members with pancreatic cancers. So you've heard this already. So for risk factors of pancreatic cancer, one can think about it as a group where it's lifestyle and behavioral, and another group where it is actually less modifiable by changes in your lifestyle or behavior. So it's clearly smoking. If you can reduce smoking, that will reduce the risk of pancreatic cancer. Being overweight is a risk factor. You've already heard about chronic pancreatitis, and in that category, alcohol consumption is something that can be adjusted for. Some of the others, like age, pancreatic cancer tends to increase with increasing age. So the median age is usually in the 60s and 70s. So anyone who's very young, that becomes a risk factor for whether or not this is potentially a genetic cause of pancreatic cancer. There are some races that may be more predisposed. In America, African Americans are actually much more likely to get pancreatic cancer. In the local context, there's less differences that we can tell based on current information, but there might be some genetic differences that we are still researching on at this point in time. In terms of gender, men are actually slightly higher risk than women, and that's attributed mostly due to the smoking and the alcohol consumption rates being higher in men. Family history, as you've heard, is important, and I'll go through that in more detail. And then we know that about 10% of pancreatic cancers can actually be due to inherited genetic syndromes, and I'll go through some of that with you as well. So in terms of family history, I will say that about 5 to 10% of patients with pancreatic cancer will have another family member with pancreatic cancer. So it is known and well known for many years that this is the case through many large cohort studies and the rest of it. But I think while we may focus on this as a potential something that we can act upon, I think it's also important to reassure the majority of you who's interested in this area that the majority of families actually majority of people who develop pancreatic cancer do not have a family history. 90% of them don't actually have a family history, right? Only about 5 to 10%. There is a term called familial pancreatic cancer. And this is a term we use in the clinic as well as in research to try and understand why this is happening. And people who are termed having familial pancreatic cancer are individuals where there are at least 2 members of the family with pancreatic cancer who are first-degree relatives for each other, meaning that they are direct siblings of each other, or the parent and child, that's a first-degree relative. So if 2 members in this kind of format has pancreatic cancer, we consider that as familial pancreatic cancer. If, let's say, there are more distant relatives with pancreatic cancer, then in terms of who has familial pancreatic cancer, we need 3 members of the family, all right? So healthy individuals who come from families with such strong family histories of pancreatic cancer do have an increased risk of developing pancreatic cancer in their lifetime. And through multiple different studies done overseas and elsewhere, they've tried to estimate what is that risk like in such families. So if in such families, if there's a first-degree relative, then the risk compared to the general population of developing pancreatic cancer is 3 to 5 times higher. If there are 2 first-degree relatives, that means you have 2 brothers or 2 sisters, or you have 2 children, or your dad and your sibling, so to 2 first-degree relatives, that risk is about 5 to 7 times higher than the general population. When you get to 3 or more first-degree relatives, 3 brothers, 3 sisters, father, mother, and 2 kids, 3 or more in that kind of context, the risk actually goes up really, really high. It's up to 30 times higher than the general population. And there's a very high chance that in this last category, there's actually an inherited genetic condition. Now, I think sometimes the terminology that doctors use, familial cancer, hereditary cancer, it might confuse patients. Not every familial clustering of cases is actually due to a genetic cause. It can be due to shared environmental and the rest of it. But when it comes to 3 different first-degree relatives having pancreatic cancer in the family, then the inherited genetic probability is actually very, very high in those folks. So this is what I mean. In general, majority, 90% of pancreatic cancer patients have what we call sporadic pancreatic cancer. This is a typical age where people get pancreatic cancers in the 70s. This is a smoker, and there's no other family history of cancer, although there's a family history of diabetes, which is a common condition. So this is likely to be sporadic, meaning it's neither familial nor hereditary. Familial pancreatic cancer refers to when there's two first-degree relatives. So sisters and sister and brothers, these are all considered first-degree relatives. So two members here, this is what we consider familial pancreatic cancer. At this point in time, this could be due to a genetic cause, or it could be due to just multiple factors, genes and environment all mixed in together, not specifically a specific genetic cause, right? When we talk about hereditary pancreatic cancer, we often think of multiple generations being involved, there being multiple people actually developing pancreatic cancer. That's when we worry about hereditary pancreatic cancer, right? And under hereditary pancreatic cancer, I will not have time to go through each of these conditions here with you, but just to share with you that our understanding these days is much better than 5 years ago about the causes of hereditary pancreatic cancer. What has happened over this last 5 years is that many families with such strong family histories of pancreatic cancers have been going for genetic testing. And so over globally, we now know a lot of information about them. The most common ones are BRCA1 and BRCA2. These are the names of the genes. And in these families, the families, in addition to pancreatic cancer, may have histories of breast and ovarian cancer, right? Another one that's very common, which I'll go through a little bit later, is hereditary pancreatitis. That means there's a hereditary reason for why people develop that chronic pancreatitis that you heard about earlier that Dr. Tan spoke of. There are two other ones which are also quite common. If there's a family history of melanoma and pancreatic cancer, we can think about a different gene. If there is just breast cancer and pancreatic cancer, we think about something else. And then colorectal cancer and pancreas, we think about other genes. And what I want, I'm not here to expect you guys to remember this, but just to understand that in the family history, it's not only the pancreatic cancer history that's important, but also history of any other kinds of cancers. What this slide also tells you is that if we know what are the genes involved that's causing the risk, we can then better look after patients and families for the other risks that they might be at risk of in addition to pancreatic cancer, so that we can ensure that the patients don't actually end up developing late-stage disease in the family members, all right? So there are multiple hereditary pancreatic cancer causes that we currently know about. So when do we suspect a hereditary cancer syndrome? Already I just shared with you, if you have two members in the family, close family relatives on the same side of the family, right? If there's an early age, for pancreatic cancer, anything under 45, we would consider relatively early. Multiple cancers in the same individual. So if someone had pancreas cancer as well as colon cancer, for example, that would be something that would be a red flag. If there's specific groupings of cancer, early on I showed you those different conditions. So certain groupings make us think of certain things. So breast and pancreas, colon and pancreas, melanoma and pancreas in the families. This makes us think of certain conditions, all right? If there are multiple generations that's affected, again, this is something that actually makes us consider this. Having said that, lack of a family history does not always exclude hereditary cancer. The other thing to say, it's not a cancer, but pancreatitis. There is a hereditary form of pancreatitis, and multiple members with this should consider having testing. Now, the thing is, many people with pancreatitis actually go undiagnosed. So pancreatitis, as Dr. Tan earlier mentioned, is a persistent abdominal pain that recurs quite commonly and quite often. So if there's a very strong family history of that kind of symptoms with someone developing pancreatic cancer, you might have chronic hereditary pancreatitis, and that's something that can be investigated for. So again, what is pancreatitis? It's an inflammation of the pancreas, where the pancreas is inflamed and then powerful digestive enzymes are then released and damage its tissue, and it creates this kind of recurrent inflammation and pain as the symptoms. And it can be acute, meaning a very short event that then goes away, or it can be chronic, meaning that it's ongoing. So it's the chronic pancreatitis that we're worried about in terms of patients developing pancreatic cancer after that. And this can have a hereditary component to it. So again, the pain is usually constant and the disabling pain, and sometimes spreads to the back. It can be accompanied with unexplained weight loss. There can be foamy diarrhea with basically oil droplets that you see. Patients may, because of a lot of the inflammation, end up developing diabetes as a result of the pancreatitis. And these are some of the symptoms and signs of chronic pancreatitis. It's actually quite underdiagnosed, if in my experience in our genetics clinic. because it is actually the most common cause for hereditary pancreatic cancer that we see in the genetics clinic is due to hereditary pancreatitis. And anyone with hereditary pancreatitis have a lifetime risk of developing pancreatic cancer, about 40%, meaning 4 in 10 of them may develop pancreatic cancer. The most common gene is this PRS1 gene here, but there's some other genes that's associated with hereditary pancreatitis. And we're starting to have some data locally that suggests that there are some ethnic specific differences between who are more likely to have different genetic changes in this that leads to hereditary pancreatitis, but that data is not mature yet, and we'll share that with people once we know more. But at the moment, it is something that we do see is not as uncommon as we used to think. And the important thing to know about hereditary pancreatitis is that the risk is actually greatly increased in smokers with these changes. Anyone with these genetic changes plus smoking increases their risk of pancreatic cancer development. So a little bit more about genomic medicine. Genomic medicine is a new field of medicine, and what we're trying to do is to try and pick up people before the disease actually starts to take off, so that we can then manage them, find the cancers in the earliest possible stages. And as Dr. Tan mentioned, if it's small and early stages, it's easier to operate rather than when it's a very advanced stage. So genomic medicine is actually a new field. It allows us to use the genetics to assess health risks, stratify groups of people into how we look after them, and then provide care plans for family members in terms of how we try and keep them cancer-free. All right. So all of us have our genes come from half of our genes come from our father, and the other half come from our mother. So this is what happens for all of us. It governs how tall we are. It governs our eye color. It also governs maybe what kind of diseases we might be at risk of. But however, the genes are not everything, because you're also influenced by your lifestyle and your environment. And based on that, based on what we've explained to you, therefore, there's a group of folks who actually will benefit from genetic testing, right? So those with familial pancreatic cancer, those with a family history of pancreatic cancers and other cancers, those who are very young when they have their pancreatic cancer, and those with a strong family history of pancreatitis, and those where you already know within the family that there's inherited genetic condition, they should go for genetic testing, okay? What actually is genetic testing is where we take your blood or your saliva and we look at the DNA to see if there are any faulty genes in those conditions that I told you about before that can actually predispose you to actually having a higher risk of developing cancer. And once we identify that, then we can be more tailored in terms of how we recommend who needs what kind of monitoring and surveillance. And this is important because when you look at a huge group in a crowd like this, it's a mix in the general population, a mix of folks with different genetic predispositions, different health exposures, healthy exposures, as well as unhealthy exposures. You can't really tell who has increased risk or no. And so with the genetic test, we can try and see whether we can pick up this group of folks here who have the higher risk of actually getting the disease. And those who do not, then actually do not have to have such aggressive monitoring, whereas those that do may need more aggressive monitoring. So what is the monitoring that can be offered? The monitoring that can be offered is that of basically an endoscopic ultrasound or an MRI of the bile ducts and the pancreas. And it's only recommended in the group where we have identified to be very high risk, meaning that the group where there's genetic changes or in a group where there's a very strong family history. The reason why this cannot be recommended for everybody, because it is not benign, these investigations, they cost money, but they also can cause complications because with the endoscopic ultrasound, it can also cause pancreatitis as a complication of it. So it's only really reserved for patients where we actually already identify them to be very high risk. Okay. I've already mentioned that a lot of this is genetic and environment. So I don't want the audience to think that there's nothing one can do. What else can you do to keep yourself at, reduce the risk of pancreatic cancer? You can keep a healthy weight. You can stop smoking if you're a smoker, if you have a family history of pancreatic cancer. You can avoid alcohol, exercise regularly. If you're working in certain factories and all that, there are certain chemicals that can worsen pancreatic cancer, but risk. And if you're in that kind of environment, you can have a discussion with and look at that. But it's a very long list, okay? And this is really a very unique circumstances only. You should be very actively aware of symptoms. As Dr. Tan mentioned, unexplained weight loss, pain that radiates to the back, or persistent pain and jaundice. These are the symptoms that one needs to be aware of. So we really strongly believe in the genetic service that knowledge is power in prevention, and that there's a lot one actually can do in terms of supporting each other, supporting your family members, as well as supporting the clinicians and researchers to try and advance this field of trying to understand pancreatic cancer risk further. I will just share with you that at the moment, there's a lot of research ongoing, both locally as well as globally, to try and understand the group that's has familial pancreatic cancer. Because right now, while we understand a proportion of them, not all of them at the moment have been explained yet. So we're still trying to understand what are the behaviors, lifestyle, and genetic factors that actually modify this risk. And if anyone's interested in this area, can contact us for participation in research. Again, so understanding pancreatic cancer risk can allow for more precise treatment, earlier and more specific cancer screening and detection, avoiding unnecessary tests for those who do not actually need it. So if you have a strong family history and we know what the mutation is for the family member, it doesn't mean that you share the same mutation. If you don't share the same mutation, you don't need to actually go for the full surveillance of the pancreatic cancer and all that. So it can save patients from having to go through unnecessary tests. In the health system, this is very important because we just shared with you how difficult it is to manage pancreatic cancer. So if we can detect them earlier, it's much better from the health system perspective. So if anyone is concerned, please discuss with your doctors regarding your family history, and then they can guide you if genetic testing is needed. So I'm just going to leave this here as where you can get some further information. Someone earlier in the chat group asked about support group. I'll say that for the individuals with some of the high risk, we do have specific support group activities and talks that happens. And NCCS has a Department of Psychosocial Oncology where you can find other support groups as well. And this is the hotline if patients need to go for genetic testing or sequencing. Yep. And I'm ready for questions. Thank you.
Okay, thanks, Joanne. That was a great talk. I think you're getting a lot of interest and questions in the Q&A as well. We will do the Q&A at the end of the whole session. So we'll go on to Ms. Juliana's talk first. So Ms. Juliana is a senior clinical coordinator in Singapore General Hospital. She graduated from University of Sydney and National University of Singapore, and she has more than 2 decades of nursing experience, with the last 15 years in her specialty of interest, which is that of patients with liver, pancreas, and gallbladder diseases. She pioneered the liver and pancreas support group in SGH in 2017. Recently, the group also received the Singapore Health Inspirational Support Group Award for their invaluable support to patients and caregivers. So today she will be taking us through a very special talk on overcoming pancreatic cancer, a patient and caregiver's journey, where she will share with us, along with the generosity of one of our patients and his caregiver, about what a typical patient may experience and what the process is like. Ms. Juliana, please.
Thank you, Dr. Joycelyn, for the kind introduction. Good afternoon, ladies and gentlemen. I'm Juliana from SGH, Hepatobiliary. First and foremost, I would like to thank the organizing committee for inviting me today, right? And so you have heard from Dr. Tan and Dr. Joanne. How about hearing from a patient and a caregiver's experiences on pancreatic cancer? I'm very fortunate to have one of my patients, Mr. Chua Kok Tai, and his daughter, Ms. Chua Yuru. But unfortunately, they couldn't be with us live today. They sent their sincere apologies, but I do have a video of them. Before I show you the video, just a little background of Mr. Chua. He was diagnosed in 2016, had a surgery done within the same year, and subsequently went through chemotherapy and radiation therapy treatment. So in this video, Mr. Chua is going to share with us on his pancreatic cancer diagnosis, how he got to know about it, his surgery journey, his recovery at home, and his chemotherapy and radiotherapy journey. His daughter, Yuru, she's going to share with us on her emotions knowing the diagnosis, how she as a caregiver helped her dad before his surgery, during his hospitalization stay, and at home, and her feelings looking after her dad, and how she had overcome her stress looking after him. Mr. Chua is going to speak in Mandarin, but not to worry, there will be an English subtitle for non-Mandarin speaking viewers. And my sincere apologies for some background noises towards the end of the video. Let's watch the video now.
Hi everybody,
嗨，大家好，
I'm Yuru, I'm 30 years old, and this is my dad.
我是义乌的父亲，我叫蔡国泰，今年64岁。
So today we'll be sharing with you our journey as patient and caregiver on the journey of how we discovered my dad had pancreas cancer and also the journey of recovery after that. Yeah, we hope that our journey will bring some form of encouragement and support to you.
在2016年3月份的时候，因为工作环境的改变，我每天需要做14个小时，再加上因为饮食的不规律，还有工作上的压力，所以造成我的体重减轻了，在两个月到3个月之内减轻了差不多3个 kg。后来因为时常有这个胃痛的问题，所以我就去看了 GP， 所以他就给我胃的药，吃完之后并没有好转，所以我再次去看 GP 的时候，看了2次，照旧还是一样，这个情况越来没有什么改善，我的血糖又增加了，所以我很容易口渴，我就去看一天看医生，医生就给我量我的血糖，说我血糖有些高，再叫我给我慢慢多2个月之后，2个礼拜之后，我的身体突然，我的尿突然变成茶的颜色，身体开始发痒，眼睛也出现了那个黄色素，所以我一天晚上我突然间很痒，所以我就去中央医院的经济部门，所以就入院。
While Mr. Chua was hospitalized, he had a CT scan done which showed a suspicious mass in a part of his pancreas. He subsequently went for a scope. Tissue samples from his pancreas was taken and the test result came out to be positive for cancer. The surgeon recommended for a surgery to remove part of his pancreas called a Whipple surgery. However, due to the extensive swelling of his pancreas, the surgery can only be done 8 weeks later after a repeat scan.
当我听到医生说我有这个癌细胞的时候，我整个人会不知所措。你不能问自己为什么会有这样的一个癌细胞，为什么会找上你？一两天之后，慢慢的调整心态，慢慢的去接受这个事实。他会先给我调理我的饮食。还有我的生活的那个起居，就是说我每天放松心情，每天运动，还有在饮食方面，我每天我喝那个果汁，还有那个中国的那个右敦草来喝。说每天我都去无下运动来调养我的身体。8个礼拜的 缓冲期，就是说8个礼拜的心态的调整，所以我已经几乎已经做了心理的准备，就像在进手术室的时候，我的心情比较平静，在那的平静，已经做好了最坏的打算。然后距离要退了之后，你会发觉到你的胸部已经到了一个很大，开了一个很大的疤痕，就在你的肚子那边有一个插管，也那个血流出来，淤血流出来，还有你的鼻子也是有插管，所以你全身都或是插管，所以你不能动，一动的话非常非常的痛。你要用麻醉剂来减轻你的痛苦。在麻醉剂过后1-2天，你的脑部会时常有幻觉，所以要有心理，要克服这个幻觉，要有这个很强的毅力。2-3天之后，开始要起来做，就要物理治疗师来指导你，叫你怎样做起来，或者下山走动，因为那个肠胃要有肠胃的移动，所以你才能够你的大便或者你的放屁才会放屁，它的肠胃才你比较恢复精力比较快，恢复体力比较快。
Mr. Chua stayed in the hospital for 10 days. The mental preparation that he had before the surgery and the support he received from his family enabled him to be at peace and focused during his hospitalization stay. Day by day, he saw gradual progress in his condition and he was fit for discharge on the 10th day.
10天之后，我回到家里，所以家的话还不能够启动，所以要躺在床上，再加上冲凉的话要坐在椅子上冲凉。所以饮食方面都前个1个礼拜都由家人来准备，每天都有在家里走1圈，走1圈差不多是10分钟到20分钟这样。2个礼拜之后，我就开始去楼下走，如果孩子带我下去楼下走，扶我下去楼下走。所以刚开始的话是走差不多100步这样，后来就慢慢开始增加了。差不多1个月之后，我就开始做皮膜化疗。所以化疗医师会解释给我他用的药，还有它的副作用，它的身体的反应。化疗总共3个月，总共是8次，所以一个礼拜1次，所以3次休息1个礼拜。期间如果有你的血小板太低的话，那个礼拜就不能做化疗，要等到血小板达标的时候才能够化疗。
Mr. Chua's chemotherapy experience was a challenging one, especially the hours after each session. He experienced dry mouth, low blood pressure, fatigue, and dry skin, but thankfully he did not experience any hair loss. Mr. Chua completed his radiotherapy treatment within a month. He did not experience any side effects and everything went smoothly.
化疗、电疗后的完成之后，已经差不多是7-8个月的时间，所以身体慢慢的已经适应，所以我每天的话就做运动，所以每天都运动，差不多从开始的半小时增加到现在的1个小时半，差不多每天都做运动。饮食方面，我尽量吃清淡的东西，就是说我吃鱼比较多，鱼，还有番茄，还有咖喱，这些粥来吃，没有吃油炸的和海鲜的，就是吃那些蔬菜和清淡的东西比较多。胃口刚开始你要小的分量， 分量要小，慢慢的增加你的分量。所以现在我都能够和平常人一样，三餐都没问题。
Mr. Chua felt that his body did not fully recover in the first 2 to 3 years. He verbalized that he has fully recovered now, and his weight went from 70 kg before surgery to 54 kg after surgery, and now 60 kg.
So what my feelings when I first found out that my dad was diagnosed with pancreas cancer, I remember actually like receiving the call during my rest after my shift at home. When I received a call from the doctor, I think in my heart I was just like praying hard that the jaundice is related to the gallbladder more than anything else. Yeah. So when I heard from her that they found a mass at his pancreas and is highly suspected for pancreas CA, I can remember my heart really sank. It's like, I can't believe that it's happening. And I remember just like going onto my knees and just really crying out to God at that point in time when I heard the news, and just wept for quite a while. Yeah.
As a daughter and a nurse, Yuru felt that she had to be strong and supportive to her dad. She was shocked and devastated by the news of cancer, but she had to put her feelings aside so that she could help her family to move on.
Read up as much as possible about pancreas CA, read up as much as possible about liver surgery. Sister Jo really talked a lot with me. What are some of the post-op complications? She really went through with me what is the needful things to do in preparation for the surgery so that the post-op complications can be minimized. So there were a few things. One is mobilization. So it's really to get my dad to keep moving, exercise. They even give him a spirometer to do spirometry exercises at home so that he can expand, learn what it's like to expand his lungs, so that when he finishes his operation, he knows how to use it, so as not to have pneumonia.
During the 8 weeks before her dad's surgery, she encouraged him to continue exercising to build up his strength. She also reinforced to him to exercise after his surgery in the ward and to follow the exercise regimes that will be taught by the physiotherapists. And the 8 weeks before her surgery, Mr. Chua was given all the nutritious food such as juices, steam, and herbal food.
Coming to work earlier, before my afternoon shifts and night shifts, to just walk with him around the ward. I remember visiting him after my morning shift and after my night shift in the morning, to just make sure he's doing okay and make sure his needs are met.
Yuru verbalized that she was his dad's nurse and a helper at home. She was also his physiotherapist, accompanying him to his daily walks and exercises around the neighborhood. Yuru started learning how to cook. She and her mum took turns to prepare the meals.
I think the beginning was still okay, but I think at some point I kind of faced a burnout because I think it's a different story when I'm just a nurse for say the 8-hour shift. But it became a 24/7 kind of caregiving role. It became very tiring, physically, emotionally, and mentally. And I think when it hit me on the emotional and mental side, I find it also very hard focusing at work in terms of the emotional capacity. I find myself walking to the hospital, just feeling a bit depressed.
Caregiving can be exhausting and overwhelming. For Yuru, she turned to her religion for peace, calm, and courage to look after her dad. Her friends were her pillar of strength who gave her the emotional support needed by spending time with her at home and at her favorite hangouts.
一线癌的康复的道路是不平坦的。几个因素能够增加我们的生存力。第一就是要有乐观的心态，放松心情，正确的人生观。还有就是在饮食方面，就是少吃糖，不要吃油炸的东西。运动方面多运动，每天都运动，走差不多尽人力去走运动，多流汗。还有不要抽烟，不要喝酒。在精神方面减少的压力，要家人的支持和精神方面的支持。在配合医疗中央医院还有癌症中心医疗团队的诊断，还有的支持，说每3个月要恢复去 CT scan， 还有 MRI， 还有做 CA199 的诊断、抽血，还有血糖的检查，说过做日常的生活，放下心情，勇敢的面对，说一定能够战胜这个癌症，就很快的就能够复原。所以在此呢，谢谢医务团队的护士的，还有护士的照顾，我的病很快的恢复了正常的生活。谢谢。
Okay, my apologies once again for that background noises. That was actually Mrs. Chua who is doing the cooking at the background here. Yeah, it was indeed a very inspiring video of Mr. Chua and daughter, and I love the words of encouragement from Mr. Chua. It has been 5 years since he was diagnosed, and Mr. Chua is well and is cancer-free, and he is enjoying each day to the fullest with his loved one. Thank you, Mr. Chua and family. Let me show you again the important tips from Mr. Chua and Yuru. You have to face situation bravely, go through every day as per normal, go for regular checkups, scans, and blood tests, which is ordered by the doctors. Good nutrition is important. You can seek advice from the dietitian. Learn more on cancer of the pancreas. You can get more information from the doctor, from the nurses, or even the coordinators. Strong family support can help to reduce stress, and going out with friends to relieve stress and to have your own time to relax as a caregiver. Additional tips that I wanted to share with you all again is everyone is different in pancreatic cancer. There will be a lot of tubes after surgery. GI system, the stomach and the intestine must wake up. When allowed to do so, walk, and walk. The patient will likely get full in a hurry, eat small amount throughout the day. No appetite, things taste bad. Weight loss, remind your loved ones that one must eat to live. Think of food as medicine. Some patients couldn't sleep in bed after surgery, so they are grateful to have recliners for their loved ones. An example of the recliners is something like this. Joining a support group is also good to find emotional and moral support from others going through similar experiences. Example is this SGH Liver and Pancreas Support Group. Currently, we organize talks and workshops online via Zoom, and we even have a WhatsApp chat group for our members to share their thoughts and to motivate one another. There are other support groups from National Cancer Center, very interesting indeed. You can find out more from their website. other online supports that you can join. These are my two favorite online support groups from Facebook, which is the Whipple Warriors and Whipple Warriors Caregiving. A lot of information from the patient as well as the caregiver. You can look up in Facebook. And you can also find out more about pancreatic cancer from online websites such as Health Hub, SingHealth, and thehealthexchange.sg. Other online websites which I like to browse through are from these websites. And this is my last slide. For those who have pancreatic cancer, remember, every hour you are healing. You are not alone. We can walk this journey together. And remember this acronym, NEGU. Never, ever give up. Thank you.
Thank you, Juliana, for that very inspiring talk. I think we really enjoyed the video and the sharing. So now we'll have a Q&A. I apologize if we are not able to get to everyone's questions, but we'll try our best to answer as many as we can. So maybe I'll start. What are maybe some of the early symptoms of pancreatic cancer? Is diabetes something that we are worried about? And would you suggest for things like screening through some cancer markers?
Who are you directing that to? Sorry. Jocelyn, we couldn't hear you just now.
Oh, sorry. Could you hear me? I'll just go again. Oh, okay. I apologize.
Okay, you're breaking up.
We'll do the Q&A again. So the first question, I think, is for Dr. Tan. Someone's asking about whether there are any early symptoms of pancreatic cancer that we can look out for. Whether, for example, diabetes is something that we should be worried about, and whether you would recommend anything like cancer screening through cancer marker testing.
All right, okay, thanks, Dr. Lee. Okay, I think those are very valid questions, and I think from a general public point of view, those are very important things to ask yourself. So I think, as I mentioned earlier, pancreatic cancer unfortunately often presents asymptomatically, and often by the time that you have symptoms and you actually seek medical attention for it, and you reach a specialist stage when they diagnose you with pancreatic cancer, it is often quite advanced already. So the problem is that the pancreas itself is a very deeply seated organ, and when the tumor begins in its early stages when it's small, often there's no symptoms, no pain, nothing. But fortunately or unfortunately, depending on the location of the tumor, sometimes it might be picked up early. So one very common scenario in which it might be picked up at an earlier stage is if it causes blockage of your bile duct, as we mentioned earlier. And this often will then present with painless obstructive jaundice, as we mentioned earlier. So if you have unexplained jaundice, definitely seek medical attention. Unexplained pain, loss of weight, loss of appetite, definitely seek medical attention as well. Otherwise, to answer that question, unfortunately, often no real signs and symptoms, especially in the early stages. With regards to diabetes itself, actually, there's a very well-known association between pancreatic cancer and diabetes. And studies have shown a very strong association, but often it's a bit chicken and egg. Some say that if you have diabetes, it's a risk factor for developing pancreatic cancer. But some do say that, it is when you have pancreatic cancer and it affects the function of the pancreas, one of which is to control your blood sugars with insulin, that you get either diabetes or your diabetes control actually worsens, which I think was shared in the patient sharing during Sister Juliana's talk earlier as well. With regards for tumor markers, I think the general recommendation now from a public health perspective is that the tumor markers we use in the setting of pancreatic cancer is not accurate enough for us to routinely recommend it for screening purposes. So what this means is that if you were to have pancreatic cancer, it doesn't mean that your tumor markers will definitely be abnormal. And likewise, if your tumor markers are abnormal, it doesn't definitely mean that you have pancreatic cancer either. So, but with that said, I think it's very commonplace nowadays with a lot of annual health screening panels that, they do a battery of tests, and often they screen a lot of different cancer markers. I think one of the cancer markers mentioned during the video earlier, CA19-9, is the most common cancer marker we use for actually monitoring the treatment of pancreatic cancer. And it's something we will measure in a patient with known diagnosed pancreatic cancer. But in terms of screening, as well as for initial diagnosis for someone who's not known to have it, currently it's still not recommended because it's not very accurate and it might actually create a lot of false anxiety and a lot of unnecessary investigations with attendant risk as well. So probably not recommended at the current moment. Yeah.
I think poor Joycelyn.
Okay, thank you very much. I think we have another so sorry. So the other set of questions for Dr. Tan is asking about after resection of pancreas cancer, what are maybe some of the complications or signs to look out for?
Okay, so I think the video sharing earlier also gave you a slight glimpse into what to expect if you're unfortunate enough to have to undergo major pancreatic surgery for pancreas cancer. So it's a very major operation. I would say that in the early phase during in-hospital recovery for the first 1 to 2 weeks, most of the appropriate complications to look out for, you probably don't have to worry yourself over it because that's what the medical team taking care of the patient will be actively looking out for. And there are various things we look at in terms of how the patient feels daily, his vital signs, the blood tests that we do, as well as the various tubes that he mentioned coming out of them from the nose, from the tummy. The tubes are what we monitor as well, and all of these will give us information on whether there are any immediate complications. But just to give you a flavor, some important complications we look out for will be any bleeding after the operation, any infection. And as mentioned earlier, the surgery involves cutting out a big portion and joining many things back together. So another concern is whether any of these joints actually leak. And all of these things that we monitor day to day will give us information on that, and then we will respond appropriately. But once the patient is cleared for discharge, long-term wise, in terms of long-term so-called complications to look out for, often it might be related to what we call pancreatic insufficiency. So maybe about a third of patients after major pancreatic surgery, even though you have some pancreas left, sometimes it's not enough. So as a result, you might not have enough digestive enzymes to digest your food. You might get, fatty oil globules in your poop, like mentioned earlier by, I think, Dr. Joanne. Then that one usually you can treat by giving you some oral supplements to help you give you the enzymes replacement that your body's not producing enough of. And of course, some patients also get diabetes or get worsening diabetes, and that can also be controlled with medications.
Okay, thanks, Dr. Tan. That was a very comprehensive answer. Okay, we'll move on to questions for Dr. Joanne. So I think there are some questions asking if I suspect, for example, I have a very strong family history of pancreas cancer or some other cancers. Should I go for genetic testing, or how can I go and find help?
So I didn't really have time to go through with you a little bit about the process. So what happens is that as long as you're worried about your family history, my recommendation is you raise it with either your family doctor or your oncologist that you're actually already seeing, and then they will go through it a little bit with you, but then they'll refer them on to the genetic service. So at the genetic service, what we do is we actually take a very detailed family history, go through who has what cancers, run through a little bit of what that might mean, and then go through explaining that to you. And then this together with you come to a decision as to whether or not genetic testing is necessary. So that's what we call pre-test counseling. That means before you do the genetic test, counseling you about what it might mean. Because I think it's not everybody who wants to have the information. So it must be that the information is useful to you and you think it's useful for you to understand how you manage your own risk. So we go through all of that because it's very easy for any of us as doctors to order a test. But at the end of the day, the test must be meaningful and must be something that you want, because even though it could be very likely that we'll find something, it doesn't mean that therefore you need to have the information if you don't want it. So it's what we go through in terms of a pre-test counseling. But in general, if there's 2 to 3 family members of your first degree relatives, close relatives, having pancreatic cancer and pancreatic cancer with some other cancers like breast, ovary, colon, those kind of cancers especially, I do think you do need to have an assessment of whether or not, because for many of these conditions, we will find the gene that's responsible for it. And based on it, then we can then manage the family members in a dedicated gene-specific way. So for example, in patients with BRCA2 mutations, they can get breast, ovarian, and pancreatic cancer. So we might be able to identify those patients who might need monitoring in the women, right, who may need monitoring for breast. And then sometimes if removing the ovaries to reduce the risk of the ovarian cancers is a strategy that we do to prevent them from getting the downstream cancers. So in general, it needs an assessment. I know a few of you put in, my family has this and my family has that, my family has that. It's a bit hard without seeing the structure of the family and then what else is going on, what ages and all that. So it's a formal consult to go through all of that with you. Yeah.
Thank you. I think one more question for you, which is there like an age cutoff or limit at which people should be going for the genetic testing?
I would say that for pancreatic cancer, the actual median age or the age where people normally get pancreatic is the 60s and 70s, right? So anyone getting pancreatic cancer, the guidelines say below 50, but I would say 50 is still quite a number of those patients who are below 50 actually do not have a genetic condition. It's just sporadic. It's just by chance that it happened. But definitely those who are under 40, under 45, that's when a little bit more of the red flags come up, that is this genetic or not? And if there's, in addition to that, a family history, then we are, more worried about that group of patients. Yeah.
Okay, thank you. And I think thank you. And I think we have time for just one or two more questions. So for Sister Juliana, I think some of the attendees here today are probably caregivers or patients themselves. So you shared with us about some of the support groups. Is there any contact if they're interested, for example, to join your support group?
Oh, yes. I was about to chat in the question and answer box. You can call me. Maybe I just let you know my number, my office number. My office number is 6576 7733. You can just get in touch with me. Then I will just talk to you and then I will see how, we can get you in touch with our support group. Yeah.
Okay, that's great. Thanks a lot. So I think Sister Juliana, she'll leave her contact in the chat or the Q&A, and those who are interested maybe can contact her after this session. And I think one more question for Sister Juliana as well is that I think some of the people here may also be nurses who are also managing patients who have pancreatic cancer. So what advice can you give to the nurses to encourage this group of patients?
Yes, nurses play a very important role, especially after the surgery or even, after chemo and all these treatments. The most important thing that they need to have the knowledge about the surgery. They need to have the knowledge about the pancreatic cancer. So it's good that, they receive information from like a specialty nurse or from the doctors or to have an in-service talks via Zoom during this time. And they need to know about the importance of the post-op care, the importance of nurses to participate with the patient after the surgery, and especially in the walking, I've already mentioned, and Mr. Chua already mentioned, walking is the best, and then we need to walk to move the intestine, the stomach. So once the nurses get to know all this information and the importance, then they will be able to participate in the care of the patient. Probably also with the help of the specialty nurses in the ward to reinforce to them, or even the help of a physiotherapy in the ward to reinforce to the nurses to get the patient to do all these exercises in the ward. Yeah.
Okay, that's great. Okay, for time considerations, I think those are all the questions that we can take for now. And I think we've also managed to cover most of the questions in the Q&A. So I'd like to thank everyone again for coming today, as well as to all our speakers, and also Mr. Chua and his daughter for sharing with us, and to SSO for organizing this conference today. Thank you.
Yep. Thank you, everyone.